Hi there. My name is Comron Hassanzadeh. I'm one of the radiation oncologists, assistant professor in genitourinary radiation oncology at MD Anderson. I would like to welcome you to our journal club today, talking on hypofractionated radiation for prostate cancer. So we're going to be talking today about our updated publication in the Journal of Clinical Oncology, looking at the MD Anderson phase 3 randomized trial of dose-escalated hypofractionated radiation for localized prostate cancer patients. So this is a study that was led initially by Dr. Kuban and Dr. Hoffman at MD Anderson, and our group published on now 13-year, so long-term follow-up of a phase 3 randomized experience. This is a randomized controlled trial of conventionally fractionated radiation that would have been done over about 8 weeks versus a hypofractionated or shortened duration of treatment over about 6 weeks of treatment. And it's also dose escalated as well, so slightly higher biological dose compared to the conventional fractionated arm. So this study had originally published its initial results at 5 years, and then it's kind of a longer term results a few years ago, and now we're presenting its 13-year median follow-up data. The primary endpoint of this study was treatment failure, which was defined in kind of two ways. One way was our classic PSA biochemical failure definition, and the second being initiation of salvage hormone therapy. So either criteria would have categorized the patient as having quote unquote treatment failure on this study. So at early time points, so at the kind of initial publication and at the kind of most recent publication, there was a difference in treatment failure for patients getting hypofractionated radiation versus conventionally fractionated radiation treatment. Now, at a 13-year update of this initial randomized controlled trial, we found that while there was a trend towards benefit, a trend towards a lower rate of treatment failure for hypofractionated dose escalated radiation, that actually no longer was statistically significant at this 13-year time point. So for kind of interesting to see that result, if you're looking at kind of the reasons why that might be, we can kind of go into those details. But that was some of the major findings of this. In addition to that, we had looked at a post hoc analysis, or I should say ad hoc analysis of distant metastases to see, do patients have a potentially lower risk of distant metastases when they get hypofractionated treatment versus conventionally fractionated? And interestingly enough, there was no difference in distant metastases between those two arms of the study. Another important finding of this study was late toxicity. And I think this is a really important finding of this study because as we look to shorten the duration of treatment for prostate cancer, the main concern from the urologic oncology community is, what does that late toxicity look like? We know that short-term toxicity at 5 years was reasonable, but what about beyond 10 years? And this was a conversation that my urology colleagues are very interested in. So an important takeaway from this study is there was no significant difference in late GI or late GU toxicity. Now, GI toxicity did have a trend for higher kind of rates of grade 2 plus toxicity. The absolute difference was 10% for hypofractionated versus about 4% versus conventional. There was interestingly no difference in late GU toxicity, however. So those are really the main highlights of the study in kind of summary. While there was an initial benefit for treatment failure for hypofractionated radiation at this long-term updated follow-up, that was no longer statistically significant, but did show a trend. Distant metastases were similar between those two cohorts, and long-term toxicity was also very similar, giving us a lot of confidence that hypofractionated radiation is a very reasonable and a very safe long-term option for our patients with prostate cancer.